Thank you. Good afternoon to you all. Thanks for the introduction, and thank you, Professor Mukherjee, for inviting me in this webinar. And thank you, Chairman and Pro Vice Chancellor, Professor Haldar, to allow me to speak in this webinar. And Professor Chinmoy Biswas, Director of Medical Education, Government of Tripura. Sir, this is my great honor to be part of this webinar. My hospital, based in Midland, UK, which serves a population more than 1 million. Two main sites we have in our hospitals, which are 8 miles apart. Both sites have emergency department. Last week, we crossed a landmark in discharging 1,000 patients who were COVID positive. We were badly affected with COVID during March and April time after the London hospitals, which were very much affected as well. We lost 2 consultants colleagues who were infected with COVID, one from the ENT department and the other one from the emergency department. And we also lost 2 healthcare assistants and a cleaner in our trust. This is very upsetting for all the healthcare workers at the hospital and put our morale very down. But we had a lot of support from the trust and the community, which kept us going. Here in the UK, now alert level is 3 out of 5. 5 is the risk of healthcare services being overwhelmed, and lockdown began, but we are now at level 3, which means viral is in general circulation and gradual relaxation of restrictions. I must do the declaration of my interest. I am not a virologist or expert in COVID-19 by any means. I have been actively involved in organizing plans and managing COVID-19 patients as one of the physicians in my hospital. Today, I shall talk about my experience in organizations and management plans for COVID-19 in anesthetics and intensive care department, and also cover the management in the intensive care unit. As you all know, COVID-19 is a recently discovered coronavirus, SARS-CoV-2. A lot of its characteristics still unknown and is always evolving new treatment and guidelines. In the vast majority of affected individuals, the infection causes very mild flu-like symptoms. And whilst asymptomatic infection has also been described, some of those infected will develop severe life-threatening disease. I was involved in those group of patients for their management. It taught us new way of working. Many doctors redeployed in different roles, which they never done it before, came to help in the intensive care unit due to increased workload. All worked in a 12-hour shift pattern. We stopped all the elective procedures in theaters except cancer surgery. We learned to work wearing personal protection equipments, we call it PPE, for hours at a stretch. The virus spread very, very fast throughout the world, as you know. In the timeline of the outbreak of COVID, the first patient reported on December the 1st, 2019 at Wuhan, China. 30th of December at Wuhan, the source was traced back to a seafood market. 2nd of January 2020, WHO named the virus as 2019 nCoV. January 19th, WHO issued warning the virus can spread human to human. And that was quite important in terms of management and treatment. 30th of January, WHO declared it public health emergency of international concern, FIC. Pandemic was declared on 11th of March 2020, and it changed our whole world, the way we live. Clearly, our world has changed over the past few weeks, none of us experienced in our lifetime. We received here tremendous community support from the Rolls-Royce company and local schools manufactured visors for the hospitals. Shops delivered free food to us. Whole nation clapping for the NHS workers every Thursday evening. And you feel you are not alone. You are all working together. It reminds me the famous Liverpool Football Club song, "You Will Never Walk Alone." Even a 100 years old gentleman, Captain Tom, who recovered from fractured neck of his femur surgery during the COVID, he started raising funds for the National Health Service. After discharge from the hospitals, he raised £23 million for the NHS just by walking in front of his house. This is huge inspirations for the whole country. So I'm just talking about how the virus spread. It spreads by inhalation of infected matter containing live virus or by exposure from the contaminated surfaces. Aerosol generating procedures create an increased risk of transmission of infection. We must know what is aerosol generating procedures because we need to take precautions for every procedures we do in our workplace. Aerosol generating procedures, in generally called AGP, are the tracheal intubation, tracheostomy, non-invasive ventilation in the ward, and mask ventilations. This all causes aerosols in the air. When the disconnections happens from the ventilatory circuits during the use, while tracheal extubation happens during the extubation's time, during the cardiopulmonary resuscitations, and also during bronchoscopy and laparoscopic surgical procedures, all produces lots of aerosols, which causes spread of infections. So we need to have the personal protection equipments during the management of the patient. The personal protection equipment, PPE, it varies what to wear during different situations in the hospitals. And there is a guidance for that. So in the intensive care unit, we have different kind of PPE, whether in the ward, we have different kind of PPE. So those are the PPE we need to have in a guidance what to wear and when. And this is going to protect all the healthcare in the hospitals. And the hospitals usually make all the PPE arrangements for all the doctors and healthcare assistants. Now I shall talk about how we started the planning when it started. Any plan will need to be fluid at that stage because the things are always evolving. This always subject to change as things evolve, like a battle plan. We are dealing with a rapidly evolving situation in relation to coronavirus. Every day we are getting new guidance. Every day we are getting new information regarding the virus. It was key that we all work together as professionals to adapt to the changing situation. So communication was a major component in this kind of situation. Our approach was establishing a command group, first of all. In the hospitals, there was 3 command groups. One was the gold, which was at the level of the board. And then we had a silver divisional level. And at the end, we had a bronze level command group as well at the departmental level. And there was daily meetings with each and every stage, and information was sent to the gold level. Command group also set the objectives and plans. what to do in the hospitals on every day-by-day basis. And there will be a huge amount of communications you need to create during this time. They started working through the objectives. First of all, the objectives was to make standard operating procedures, SOP. We have to make new guidance for the coronavirus. We have to make a guidance for the infection control, how we can be prevented, the patients as well as the doctors and healthcare workers. And also need to make a guidance for the PPE, personal protection equipments. And these PPE is going to protect the healthcare workers. And at the same time, it protects the patients as well. So PPE guidance, there are the WHO guidance there, and we have to follow and make it our own guidance, whatever available in our own hospitals. And that's what we did in our own hospitals. We have our own PPE guidance, and which was distributed to different departments. We also started training in different aspects of new COVID-19. As you know, there was a lot of redeployment of doctors in intensive care unit because huge amount of patients was admitted in the intensive care unit. And we needed a lot of different doctors to work with us. Came from orthopedics, came from general surgery, came from medical ward. And they were not used to working in the intensive care unit. So they all needed training in there. In terms of communication, our Chief Executive Officer, CEO, sent out regular emails and sent out live video conference, and also sent out SITREP. I'm not sure whether you understand SITREP because this is a new concept that came out from the battlefield situation. SITREP is a daily report which describes what is happening in the whole trust. For example, the SITREP report used to tell us every day how many COVID patients are being admitted in the hospitals, how many COVID patients are in the intensive care unit, how many of them are intubated, how many patients are being discharged, and how many patients are dying every day. And also, it reported us about the sickness, COVID sickness, how many doctors and nurses being sick and they're out of work. And that will help us to manage our workforce as well. Workforce obviously was a big issue that time because of this sickness. So we identified availability and expertise in staffing groups allied to the critical care like anesthesia, surgical and medical specialties, specialist nursing, ex-critical care staff, rotating junior doctors to work in the intensive care unit, helping donning and doffing personal protection equipment. And also, we need to prone the patients for 12 hours interval in the intensive care unit, and which required huge number of personnel to help in proning the patient. We formed Mobile Emergency Rapid Incubating Team. We call it MERIT. It involves an anesthetist, it involves a technicians who will be ready in the hospital's 12-hour shift pattern to go and intubate patients in all over the hospitals, in the emergency department, in the ward, and in the intensive care unit. So staff subgroups were quite important, how to make work in different areas in the hospitals at that pandemic time. Infection control champions was there in different sites of the hospitals, and they were helping in making PPE available and also make sure that every doctors and nurses, they follow the infection control policy. It is important at this time to empower the team to their responsibility and challenging others to follow the policy. Then we started training all the junior doctors, all the consultant anesthetists, intensivists, recovery nurses, theater nurses, plus theater technicians in different aspects like how to don and doff, PPE. Don means wearing and doff means how to take it off safely as well. Guidelines were prepared and we rehearsed on how to do intubate in a COVID positive patient, and we used simulations to train the doctors and nurses to do that. And also we had a practice how to prone, because proning is not an usual thing we do every day in intensive care unit. But these patients were quite helpful. If we prone them, their oxygenations improved profoundly. So proning was new concept came out in these COVID situations. Familiarity with the ITU equipments, with the infusion pump, with the ventilators, and also we need to have, everybody need to have basic critical care nursing and medicine knowledge. So all this training were going on at the same times. So these are all part of the preparations for dealing with the COVID pandemic at the beginning, which started in March in our hospitals. Before management of the patients, quickly, I will talk about COVID-19 underlying pathophysiology. COVID-19 appears to have several phases. Early phase of respiratory failure primarily affects the vasculature of the lungs. Procoagulation leading to the microvascular pulmonary thrombosis. Lung compliance is generally very good. It's not an issue to ventilate the lungs. But in later stage, the respiratory failure, they involves ARDS and the bacterial pneumonia. And that time, ventilation becomes a huge problem. So initially, ventilation not a big issue, but slowly it developed to ARDS, and we struggled to make the oxygenation better in those patients. And that stage, proning helped quite a lot for our patients here. The key features of severe COVID-19 is hypoxic respiratory failure. I've seen in emergency department, young patients gasping for air, and we had to jump in to intubate in those very, very sick patients. Patients with severe disease may also develop progressive multiple organ failure, like kidney failure and heart failure. The current mainstay of treatment is supportive care for this treatment, because there is no definite treatment still available for us. Most of the patients needed oxygen. The shortage of oxygen was a national issue at a stage. We had oxygen supply failure situation in our hospitals, and hospitals at that stage diverted all the emergency to our other sites. It will be necessary to work with the local oxygen engineering team to understand the limitations of your local system, which is overwhelmed with so many patients are having oxygen therapy. Assessment should be made of the number of outlets that can be simultaneously supported by the central supply of oxygen and the location of those outlets. The hospital engineering team can determine the flow rates that can be achieved and types of ventilator it's supported. The problem is because huge amount of oxygen is being used, the liquid oxygen is not getting enough time to be as gaseous forms, and deficit comes there and then fails to supply the oxygen in the central pipe system. Communicate to all the staff about the requirement to reduce the oxygen consumption through avoiding hyperoxia and eliminate the oxygen waste. Oxygen therapy guidelines was produced and generally aim for the saturation of oxygen for the patient 92 to 96%, although the target may be lower in some patients group as well. Avoid high flow oxygen delivery devices. There is no survival benefit compared to conventional oxygen therapy, and the risk of environmental viral contaminations may be higher due to aerosol generations. Eliminate the waste by ensuring oxygen flow meters are switched off when not attached to the patient. Cylinders filled and kept in reserve to facilitate transfers and emergency use. Non-invasive ventilations was used in the ward. Use of CPAP or non-invasive ventilations should be confined to the short period of time using a well-fitting interface mask. As a bridge to invasive mechanical ventilations, because non-invasive ventilations only can bridge that gap only. For some patients, non-invasive ventilations will form the appropriate ceiling of care, and they may not need to be prepared for invasive ventilations like intubations and ventilators in the intensive therapy unit, depending on the case of that situations. It is preferable to deliver non-invasive ventilations in an isolated environment, especially in a neutral pressure room, because this can spread the aerosols to the healthcare workers and to other patients as well. If possible, an antimicrobial filter should be located to the expiratory limb of the non-invasive ventilation device. I will talk about a bit of mechanical ventilation in the intensive care unit. Aggressive ventilation in the early phase may adversely affect the later outcomes. The starting PPE and the tidal volumes, the PEEP should be around 10, and which appears to be satisfactory for many patients at the initial stage. As I mentioned before, proning the patient should be considered early in this sort of patients to support the vasculature of the lungs. Using the cutoff PF ratio less than 150 millimeter of mercury for pruning is ideal. Using pruning team, because you need at least minimum 6 people to prune the intubated patients safely in the intensive care unit. So you need to have a pruning team on regular interval, and pruning usually done 12 to 16 hours overnight every day. Pulmonary vasodilatations may provide short-term benefit, and pulmonary vasodilatations are being done with nitric oxide or nebulized or intravenous prostacyclin. But this has got very short time limitations. It probably gets refractory after 96 hours or so. Cast formation and plugging the small airways can happen in the intensive care unit, and which can be affected by the dry circuits. So that's why we need to have a humidification of the circuits, which will be very beneficial in this sort of patients. Using the checklist to make sure the heat and moisture exchange filters, HME filters, doesn't get clogged on regular basis. We need to check them. Make sure every 12 hours we check them, as it is important in the context of reduced nursing ratio in this sort of scenario where probably huge number of patients coming to intensive care unit we are not expecting. Severe upper airway swelling in some patients may make the extubations difficult at the end of ventilation. So using dexamethasone prior to extubation, having nebulized adrenaline available with surgical airway expertise available, like ENT surgeons available on site. A mobile airway team sometimes helpful. Make sure if there needs reintubations, they are available. So reintubation rate within 24 to 48 hours was quite high in this sort of patients. And in our experience, probably 50 to 60% patients needed reintubation. So delaying initial extubations for longer than usual may be sensible options in this case. We have to have renal support for a lot of this kind of patients. Renal injury has been more common in these cases, which was anticipated around 20 to 35% of ITU patients. Renal microthrombi or even direct viral injury to the renal tubules, conservative fluid strategy may be the reasons for this. careful attention to adequate hydration, and use of lower PEEP may help. PEEP means positive end expiratory pressure. Consider commencing therapeutic anticoagulations from the beginning with low molecular heparin or unfractionated heparin will be useful. At presentation to hospitals, many patients are significantly dehydrated. This may contribute to the higher than expected rate of acute kidney injury, and also it causes ventilation perfusion mismatching, VQ mismatch. Balanced crystalloid solution should be used for the acute resuscitations of shocked COVID-19 patient. Once patients have been adequately resuscitated, the aim should be to maintain euvolemia. Careful use of fluids towards euvolemia may be beneficial in early phase disease to prevent renal failure. Antibiotic use should be very judicious in this case. Consider not commencing antibiotic empirically at presentation. Continue to follow local antimicrobial policies, guidelines, which you have. Continue to practice good antimicrobial stewardship with regular review to stop, de-escalate, or switch on to oral or enteral route. There are some reports of later aspergillosis and candida infections on intubated patients in the ITU. There's another thing happens in COVID-19 patient is called cytokine storm. In this disease can be fatal due to an overreactions of the body's immune system called cytokine storm. We see a lot of patients coming with neutropenia. They're coming with high ferritin level and had a DIC picture in their blood reports. Methylprednisolone has a role in this sort of patients. When all the ventilation strategy fails in our intubated patients, then we refer these patients for ECMO therapy. We haven't got ECMO in our hospital, so we have to send it to specialist centers for ECMO therapy. We also need to think about the routine medications managements, because this is the time where there will shortage of important drugs can happen. And to prevent the shortage, we have to think of the alternative drugs we can use for. For example, in ITU for sedations, normal protocol is using propofol, fentanyl, or alfentanil. But in this situation, we have to think of using midazolam and morphine infusion. For muscle relaxant, it's important not to use important routine drugs, atracurium, cisatracurium, because these will be very less available at that time. So we have to think of old medications like pancuronium and rocuronium. We have to use vasopressors, noradrenaline, and if we haven't got noradrenaline, I think we have to use second-line drugs, adrenaline, for inotropes. Cardiovascular system was not a big problem most of the time. They only needed for sedation-related hypotension treatment with metronidazole or phenylephrine. Stress ulcer prophylaxis from intravenous ranitidine, you can switch on to PPI if ranitidine is not available, and stop once enteral feed started. There is some hope for specific treatment for COVID patients now. There's a recovery trial from Oxford came up last few weeks ago. The recovery trial, over 11,500 patients had been enrolled from over 175 NHS hospitals in the UK. A total of 2,000 patients were randomized to receive dexamethasone 6 milligram once per day, either by mouth or by intravenous injections for 10 days. And they were compared with 4,000 patients randomized to usual care alone. Dexamethasone reduced deaths by 1/3 in ventilated patients and by 1/5 in other patients receiving oxygen only. There were no benefit among those patients who did not require respiratory support with dexamethasone. No clinical benefit from use of lopinavir or ritonavir in hospitalized COVID-19 patients studied in the recovery trial. We all know hydroxychloroquine trial, it stopped after withdrawal of two important papers came out in Lancet and Journal of American Medical Associations due to data mismanagements. So we're not sure where we are with hydroxychloroquine tablets in this management of COVID. Remdesivir and favipiravir, there's no control trial showing benefit yet. So we don't know what to use exactly at this time, any antiviral drugs. New claims every day, including, I think we all know the controversy happens in India, Patanjali. I think we have to be very careful at this time, not to get from any source for any kind of management and treatment. We need to look for randomized control trial. Otherwise, it's not useful at all. It's going to be very fatal in some patients. My talk remains incomplete if I don't mention about ethics in managing resources during pandemic such as this. Our decisions should be guided by the ethical principles, fairness, duty to care, duty to preserve resources, transparent decision-making, and accountability. To protect against moral injury and to provide support for the individuals, doctors, and nurses, difficult decisions regarding admissions, resource allocations, and withdrawal of life-sustaining treatment should ideally be made by more than one clinician within a multidisciplinary team. These decisions should also be discussed with the patient and their representatives where possible. Decisions should be aligned to the local or government guidelines and should be documented in a clear manner. Hospitals' ethics committees can also help with particularly difficult decisions, especially where there is disagreement between the clinical team and patients or their representatives. Now, in UK, in our hospitals, we are in this next phase of after our acute crisis. We have already crossed that acute crisis. Now, how to planning how to work in a world where there will be significant COVID-19 presence for many months to come. This will test our resilience as an organizations and as individuals. We'll be looking at how we use our buildings, how we can create a separations of patients' flows for those with COVID-19 and those with other needs who are coming for normal elective procedures or cancer surgeries not infected with COVID. How we can help our people and the public observe the social distancing in our workplace. So we produced green and red pathways. Red pathways for COVID-19 suspected or positive patients, and green patients are who are negative COVID and who had isolations. So those who are coming for elective procedures, now they have to have 14 days self-isolations at their home, and they will have a COVID test 48 hours before their elective surgeries. And they will not going to be mixing up with the red pathways. So there will be two different sites for this kind of patients as well. So this is a huge amount of task we have to go through at this time. Obviously, there's some good things came out from this COVID pandemic. The pandemic has also acted as a catalyst for change. We are working differently in so many ways, some for the better, which we'll want to keep for future working pattern. In our hospitals, our discharge process have been transformed with patients able to leave within a couple of hours once the clinical decisions has been made, and earlier used to be a day. In our outpatients, we have seen a dramatic shift towards telephone and video consultations. which are more convenient for patients and also helped us to reduce the numbers of patients attending our hospital. There will always be a need to see some patient in person, but this is a change that we and our patients will want to see to be maintained. There is also virtual clinic happening in our hospitals where the doctors, physicians, and other healthcare professionals sitting together on the computer, looking at the patient's notes and decide their following treatment plan. And also we are having online teaching, learning all the time. I think we have more opportunity now to have knowledge and understanding toward the world with this online teaching and learning platform. So with these notes, thank you all for listening and stay alert, control the virus and save lives. Thank you.